Director of Marketing at Prediction Software. Today we'll be talking about bringing predictive analytics to the point of care. The session will be presented by Nish Hartman, Director of Healthcare at Prediction Software, and Dr. Jean Wright, the Chief Innovation Officer at Carolina's Healthcare System. We have a lot of great content to share with you today, and your presenters will do their best to keep the presentation to around 45 or 50 minutes to allow for plenty of time for questions within the hour you've set aside for us today. Please feel free to enter your questions in the questions pane on the chat window for GoToMeeting at any time during the presentation, and we'll answer them at the end of the session. So without any further ado, I'd like to go ahead and hand things over to Nish Hartman to get us started. Nish?
Thanks, Jennifer, and thank you all for joining us in this webinar on bringing predictive analytics to the point of care. This is Nish Hartman, Director of Healthcare for Prediction. We're privileged to have Dr. Jean Wright, Chief Innovation Officer for Carolina's Healthcare System, join us. We'll share with you information on Prediction and how Carolina's Healthcare uses it to provide actionable insights at the point of care. With the changes in healthcare reform, organizations have to do something different to accommodate the shift from volume to value-based care. As you can see from the quote here, the key in making this shift is analytics. As evidenced by the Gartner spending chart on the right, all healthcare organizations have key initiatives going on right now in business intelligence and analytics. Specifically, predictive analytics is a hot topic for many organizations right now, not just in healthcare, and there's a valid reason for this. Predictive analytics really pays off. Look at this stat. According to Gartner, organizations that use predictive business performance metrics will increase their profitability by 20% in 2017. That is an impressive ROI. With numbers like that, it makes you wonder, why isn't everyone using predictive analytics? Well, the reason is it's difficult, really difficult. According to a recent report by the Aberdeen Group, the top two reasons are based on a lack of knowledge and skills. There's a huge shortage of data scientists that you've maybe read about. These are super smart people who have mastered mathematics and statistics. There's not a lot of them, but they do very important work, and they need help expediting their work process and expanding their influence into the organization. You can see that two other reasons here have to do with the business not understanding the value, lack of support, and difficult to quantify ROI. One of the main reasons for this is that it's so complex and so difficult to get it right that it takes a lot of time to do it. And by the time the business sees it, they've moved on to other problems. Also, while data scientists are great at what they do, they often do not understand the business needs. They need more interaction and collaboration with analysts who know the business to understand what value they can add. Prediction wants more organizations to benefit from the great work that data scientists do. In fact, we believe that predictive analytics has the power to create a better world, a smarter, safer, and healthier world. So what we want all organizations to be able to use this great technology, and with Prediction, they can. If more organizations use our product, we can create a better world. This is what drives our employees. We envision a world where you can predict everything. Prediction simplifies the entire process to get actionable predictive insights at the decision point faster than anyone else. We do this in two ways. Our self-service predictive analytics platform. We have an innovative platform for data scientists, business analysts, and others to create predictive models quickly and deploy them easily into production. Everything is expedited, from preparing data to sharing with others and automating into production. Predictive applications is the second part. Using our platform, customers can create user-centric predictive applications that quickly and easily present the information in a clear and concise way so that you can realize the return on being predictive immediately. What you see here is really a diagram of how this whole process works. In the center is our innovative platform. This is where the data scientists and business analysts collaborate to prepare, build, collaborate, and deploy models. Everything from here is expedited to deploy into production. And the interface that we use is the #1 BI tool in the world, Excel. The back end of this is SQL Server Analysis Services, Reporting and Integration Services in Azure. Then we deploy predictive models in a variety of different environments, including SharePoint and some of the other environments that you see here. The MLSM, Machine Learning Semantic Model, is how we deploy and enable repeatability of the predictive process. In short, these are multiple tedious steps involved in preparing and shaping data for the predictive model creation process. You can see them all here from your schema to multiple transformations required. When building a model with prediction, many of these steps are automated. In fact, these steps are encapsulated in a single workflow called an MLSM package. That is then portable and more easily and rapidly deployed in a variety of methods. Because of the portability offered by MLSM, Predixion enables the flexibility to deploy anywhere to solve a variety of use cases. As you see from this slide, it can be deployed into BI tools, into existing applications like electronic health records, custom web applications, portals, and devices. Predictive analytics or advanced analytics is a very crowded marketplace right now, with a lot of emerging players, and just about everyone is claiming to have a solution in the predictive analytics space. So it might help you to understand how we are different. All players generally fall into 3 categories. First, on the left, there's the tool for data science. There's a lot of them, and they are all very similar. They all have predictive model creation tools that were designed specifically for data scientists. These are highly sophisticated products. They're complex, some come with a big price tag, and a lot of the emerging ones are less expensive. Data scientists really like these tools, but the business often struggles to see value from them because they're so complex and because it takes a long time for the business to see or understand what value they provide. On the other extreme, in the second category, is the black box solutions. These are not tools for data scientists. These are applications designed for business users, and they typically solve a niche problem using predictive models. For example, credit scores, marketing optimization applications, predicting the weather, or predicting the mortality rate of patients. There's a ton of these in different industries. They solve one problem and you're not really sure how, but you trust that it works. The business likes these because they really don't know how it works, but it solves the problem and is usually rather easy to deploy. Data scientists, on the other hand, don't like them because they can't access it to understand or validate how it works. And let's face it, our markets are all dynamic and things change quickly. So if these models aren't refreshed, they get outdated pretty quickly. In the third category is prediction. And we are alone in this category because we're addressing the market differently than anyone else, as we offer the best of both of these worlds by solving the needs of both the business and the data science community. With our focus on speed to deployment, the business gets immediate results in analytics applications that can be easily consumed by non-technical users to help improve decision-making and outcomes. And for the data scientists, we offer an easy-to-use yet powerful platform that can leverage their existing algorithm packages and models. Plus, it's 100% transparent and auditable and configurable, so they trust how it works and can tweak it and refresh it when needed. It will also help them demonstrate their value to the business by increasing adoption of their work. And it's not a one-off lockbox, but an investment that will grow with your organization that can continue to be leveraged to address additional use cases in the future. And something that Predixion is doing that is totally unique is that we have the ability to empower analysts or Excel power users with predictive capabilities, meaning access to predictive models that can be used in a single click to gain valuable insights. Speed is paramount when it comes to making predictive insights a competitive differentiator in your organization. This is a great chart on the value curve of predictive analytics. Interestingly enough, there are a lot of companies that provide tools for predictive model creation, but many of them do not focus on how to deploy those into production. But that is really when the organization receives the most value from predictive models. You can have the best data and the best models, but if it's not in use, if your business isn't using it to drive daily decisions, then you're not really realizing the true value and potential out of your data investments. Predixion covers the entire value curve, from data prep to information consumption. You can use Predixion to prepare your data for predictive analytics, create models using a wizard-driven interface, which business analysts love, or you can integrate your existing model creation tools such as R and just use Predixion to collaborate, integrate, and deploy models into production. Either way, we speed the deployment of predictive analytics into production, which is where they become valuable to your organization. Predictive analytics is complicated. We take the magic out and apply a very simple yet proven method for getting started with predictive capabilities. It's called predict and intervene. It's our experience that most machine learning problems can be solved using this methodology, which combines segmentation model with classification model. This can be applied to a broad set of problems that span industries. Let's look at a few examples. Let's talk about 3 high-profile problems that are really costly in the healthcare industry right now and how Predixion helps address them. Length of stay, where 34% of inpatient days are avoidable and unproductive. This is a massive expense in ways that can be easily avoided using predictive analytics. The graph on this side shows how the averages vary from state to state. Preventable readmissions, where we see over $25 billion in wasteful spending. And then lastly, hospital-acquired infections, where $35 billion a year is spent on caring for people who acquire infections in hospitals. And sadly, 100,000 people per year will die for such infections. Let's take a look at how predictive analytics can add value in the context of these very high challenges. Prediction's predictive analytics technology plays a critical role in providing information that's both delivered while the patient is still in the hospital and at an individualized level. But what really makes Predixion impactful is something we call the last mile. This is serving up the risk scores and interventions in a very clear and simple to use interface. This is where the true value of your data is realized at the point of care, with actionable insights delivered in real time that can be acted upon immediately. Now it's my pleasure to introduce you to Dr. Jean Wright, Vice President of Innovations at Carolinas Healthcare. Dr. Wright will share with us Carolinas Healthcare journey with the last mile, particularly for readmissions and length of stay.
Thanks, Nish. If you could go ahead and move to the slide that looks like a graph, we'll get started with this portion. It probably makes most sense to talk about how did we raise the question of using predictive analytics. It actually began a couple of years ago. I was a principal investigator of a Beacon Community grant, about a $16 million grant that was using health IT to improve population health. We picked a patient segment that we knew had many challenges when it came to really creating an effective disease management program for them. And that population was the group of patients who have COPD. Now, as you can see from the chart, our data runs back to 2010, which was the beginning of our grant period. We knew at that point in time that COPD was not one of the conditions that was currently being measured and penalized under the CMS system, but we knew it was on the agenda for 2013 and 2014. So we thought, wow, if we could be smart, if we could get ahead of the curve, we could build this program before the penalties are put in place. And in fact, we did, and we were quite pleased with the results. And as you can see, over about a year and a half, 2-year period, we were able to drop the readmission rate from 21% to about 14%. In fact, if you could see behind the sticky note, it even dropped down to 13.5%. But I think the part of my past that was an academic at heart realized I probably shouldn't trust my own data. Not that I couldn't trust that the readmissions had dropped, because we were very clear. We were using CMS definitions, 30-day, all-cause. We knew that it was the same no matter where we were measuring it. But the academic in me said, what caused this? Was this improvement just because all hospital systems are focused on readmissions, and maybe the work around heart failure, pneumonia, chest pain, maybe that was just rolling over and impacting other admissions. Maybe it was because this particular community had a lot of embedded case managers. We have a very novel application of Medicaid in the state of North Carolina, and there's a lot of communities that have embedded assigned case managers, and maybe that was the fact. Maybe it was the fact that some of these practices had embedded behavioral health resources. So I wanted to step back and tease apart this data, because I knew this data would only be important if, first of all, if it was sustainable. Secondly, if we could reproduce it. You know, we're part of a healthcare system that covers North and South Carolina. We have about 40 hospitals, about 900 locations. So it would not be adequate for me to build a model that only worked in one particular environment. And then it would really be helpful if we could figure out what driver or which drivers were most important in impacting readmissions. It was right about that time I met Nish. We began to talk about those common questions, like what problem are you trying to solve? And I said, look at this data. Here's what we're trying to solve. What is it that really is the most important factor or factors in driving readmissions? Now, because I did have a background of using logistic regression in previous lives, I knew that there had to be some tools out there, but I didn't know how much the field had changed over the last 10 or 15 years. Nish, if you'll progress to the next slide, we see a couple of selection criteria. These are the questions that are at the top of my mind, and in fact led us to our decision around Predictive. To build a review of articles being published. Some of the predictable or the reliability of the predictable models was a little above chance. Some of it was showing some hopeful trends, but we wanted a strong, reliable model. We also wanted a model that could use our data. I think a lot of us are concerned that when models are built in other communities, it may not reflect what's actually going on in our own backyard. So if you have a pulmonary rehab facility in your backyard, your readmission rate is going to look different if patients have access to that. If you're like some of the colleagues I've talked to in the Chicago market, some of the hospitals there have a high readmission rate related to sickle cell. Well, it wouldn't help them to use a model built off of my data if they couldn't modify it or alter it for the conditions in their community. The third criteria was, could we do this in a live environment? Most of my past as an academic physician was in an environment where the data scientists sat in a dimly lit room off campus churning through hordes and hordes of data. Was there some way that we could change that paradigm and actually bring that information to where the case managers were making the decision? You know, it's too little too late if the person's already sent home, and then we realize, wow, that was a high-risk patient. I really wish we'd sent home health home with them, or I wish we'd made a sooner follow-up appointment. And then the fourth bullet says, could we get it in the hands of clinical users? Most of the tools I had seen around predictive models, around analytic models, around regression, were really things only scientists or business analysts used. What about something that had such a friendly user interface that nurses could use this on a daily basis? And if I had a magic wand, could I have a program where we could use our clinical users as part of the design process? That's a concept we're deeply wedded to in the Carolinas healthcare system, because we believe people on the sharp end of the spear, closest to the patient, often have the best insights into what makes a difference. And then, like all people, we want it quickly. Could we do it tomorrow? How long would it take? And in fact, some of the companies that we talked to, it was going to be about a year or 2 years to build and validate a model. So as you see this list, here are the things that were top of mind and led us to this decision. If you'll move ahead, on the next slide, a little time delay here.
Jean, your slide is being displayed now.
You now see a chart that says our problems have become also your problems. We knew that this problem around readmissions wasn't unique to just us. If we had a problem with readmissions, we knew that this would be a national problem. And so we tried in the planning process to build a model that would be adaptable, not just for people at Carolinas healthcare system, but for any other hospital or healthcare system. And in fact, we know that readmissions is not a one and done problem. You know, many of us got our feet wet in 2012, 2013 in this field, but as the pie chart on the right shows, in 2014, we still see an increase of penalties. Hospitals and health systems are grappling with this even as we speak. If you'll move forward to the next slide, you'll see that in these colorful boxes are some of the variables we used to build the model. We actually started out with more variables. We started out with about 200 variables, some of which were clinical, some were demographic, some were related to the procedure that was being done. But over time, and those of you on the call that are used to doing modeling know that you can refine the model. And we can get it down to the 40 most important variables that would really build the most robust predictability. Next slide, please. And so as in all good health systems, we're addicted to acronyms. Our most recent one is PCPCS. It stands for Patient-Centered Point-of-Care Clinical Decision Support. This is the team list, data scientists, case managers, and those on the front line of clinical care. And this becomes our learning lab. This team of individuals partners together in a cross-disciplinary way to learn about readmissions and learn how to do point-of-care decision-making based on analytics. Next slide, please. if you're to approach something like this, who should be on your team? Well, you'll have to decide what's best for your institution. As I mentioned in the previous slide, we're really committed to a multidisciplinary approach. And in particular, as these three call-outs from articles and web pages indicates, we knew nursing was a critical element. I'm not a nurse by background. I'm an anesthesiologist and intensivist. But I think because I have practiced my entire career in a team environment, I know how important nursing is, particularly when it comes to transition of care, discharge planning, and case management. So they were a critical element to be involved in both the planning, the design, and the rollout. Next slide. On this slide, you'll see two views that our case managers can use, even today as we speak. I think I'll have Nish advance one more slide so we can see these in larger versions. One version of the slide is the patient list or the patient view. So Nish, if you can advance to that slide. Here we go. So on the left-hand side, if I were a case manager, let's say on 4 Tower, I would walk in, turn on our access, and take a look. Let's go back, not patient interventions, but the slide before, where I can see as a case manager what my workload might look like that day. That's it. And you can see on the left, and these are de-identified, not real patient names. But next to every patient's name and room number, there's a risk band. In fact, as we built the model, we decided to segment our patients into at least 4 groups: very high, high, medium, and low risk. So you can see over on the right-hand side how the percentage of all patients divvies up in those different groups. As you look below, it says increase risk indicators and decrease risk indicators, and you can see which of the specific variables cause someone's risk band to either go up or down. What does that mean? It means if what are the things that drove that? Well, it may be, like in her situation, that she's had a left hemispheric stroke. That's probably not a variable I'm going to be able to answer. But perhaps, if one of these variables had to do with her anemia or her electrolytes, if I kept her another day or so and improved that clinical condition, I could, in that moment of time, measure her risk of readmission and see if it would in fact change. So this is real decision making using live clinical information right at the point of care. Okay, let's look at the next slide, which then shows you the screen that the case manager interacts with. On this screen, she's looking at the patient demographics. It looks a lot like information you might get from an ADT feed. Again, you see the individual risk indicators up and on the right. And then on the bottom left, it shows the recommended interventions and then the selected interventions. So if you can click one more slide, we'll see that for this patient, I believe it's made up patient Tracy Jane, that the case manager is going to pick telemonitoring, and there, click, it shows up in the bottom right. So now, in addition to looking at the wristbands, you can then make a decision, use an intervention that you and your team will have chosen based on your knowledge of the evidence, and then you now create a permanent trail as to which intervention you have applied to that patient. All right, let's move to the next slide. So here's our story, or our tale of Implement 13, and by midsummer we were beginning to roll this out. If you have a system that has a similar architecture, a data warehouse, perhaps use the same EMR that we use, your implementation will actually be a matter of days, or perhaps, to work with your data. Some systems that we've talked to have said, well, we haven't built our data warehouse yet. Can you pull this from individual sources? And the answer is yes. So if you have not yet integrated or built a data warehouse, you can still get to this information and build it. It takes a few days to train the end users, the case managers. They quickly learn how to use the fields and negotiate around the screens, and then you're good to go. Next slide, please. The interventions that you apply to this model are based on evidence. And we know whether you use the Boost model, the Naylor model, the Coleman model, each of those has evidence-based medicine around those. But you have to apply them in the context of what makes sense to your area. Do you have a specific heart failure clinic that you want your patients to be seen in after discharge? As I mentioned earlier, do you have pulmonary rehab? Do you have home health in that zip code? Where do you have access to palliative care? Do you have a particular clinical program like sickle cell that needs referral to a special clinic? All those interventions you will build as you're building your model and building your tool. Even though I'm in Metro Charlotte the majority of the time, I can drive as little as 30 miles away from downtown, and the answers to each of those little dash questions is different. And so you want to really make it specific to that hospital and that referral base so the tool means the most to you and your users. Over time, you can figure out, do these interventions really move the needle? Should I add some different ones? Should I alter or drop them as resources become available in my area? I recently heard a story in the book called The Quants, where they talk about how Cigna has used some information like this. And Cigna used their predictive analytics to help them understand readmissions, and not just who was being readmitted, but where were the programs working. So you can use this as a self-diagnostic tool to say, wow, in the areas where we have embedded case managers, does that make a difference over the areas where that's not available? Or we've just put in a system-wide approach to COPD. Are we bending the needle the way that we had intended to or hoped to? Next slide, please. So let's look at the results. Let's move ahead to the strength of the model. My kids and even my students at time will say, Dr. Jean, you're using some really geeky language. And so, for the analysts on the call, I apologize because this isn't geeky to you at all. But if you're like most of us, we don't usually read this stuff for bedtime reading. So the curve on the left says if it was a coin toss and we were trying to guess who would be readmitted, there'd be a 50-50 chance. Anytime the model is stronger than 50-50, it moves up and to the left. And so for the model that we built, the area under the curve, or the CSTAT measure of accuracy, is about 0.79, 0.8. What does that mean? It means about 80% of the time when we work off the model, we are right smack on target. If we say someone's got a high risk of readmission, that patient's probably going to be readmitted. And if we say it's very unlikely, then they're probably not going to be readmitted. In fact, you can see below the yellow bar the names of a few of the other models that are frequently referred to in the medical literature, and none of them has as high accuracy as the model we've been able to build between Predixion software and Carolinas Healthcare. Next slide, please. This bar graph shows you the ways that we can validate the readmission risk model. It's just one more way of saying, did those who scored in the very high group end up being readmitted? And the fact is, they did. And so, not surprisingly, when we go in and pull the data out after the fact, we can say our model pointed us in the right direction. In fact, we have built in our culture and built into an element of using this tool a discovery process so that when somebody is readmitted, we go back to the case manager who discharged them and said, how did the model predict their risk of readmission? Because we want to see, did we miss something? Did we not capture them correctly? And then what interventions were recommended and which ones were assigned to the patient. We then do a root cause analysis on that failed readmission to see, Did we score them wrong? Did we give them the wrong intervention, or did they not follow the instruction? I think many of us have found at times it's too easy to say the patient's not compliant. And the reality is that's not usually the reason. It may be that they didn't get their prescription filled because it wasn't on their formulary. There could be any number of reasons, but this allows us to do that deeper dive and get more accurate insights into what's really driving that readmission. Next slide, please. So what does this mean for Caroline's healthcare? It now means that after a year and a half of working on this tool and bringing this into our culture, we have completed the installation in the first 7 hospitals, and they have over a year's worth of experience. We now have it fully deployed at 13 of our metro-based hospitals. That means over 100,000 patients at the time of discharge have been managed with us knowing their 30-day risk of readmission. We're able to go back and say, how many interventions did we apply to patients? Well, those of low risk or medium risk, we don't need to apply very many to them. So the majority of interventions get skewed to those in that high and very high risk. And at this point, we're over 120,000 interventions that we can track. And I think a very strong point for us is because we are a large system, when we do something, it gives us an opportunity to test how does something scale. And we now have 208 case managers who are actively using the tool. So it's not just feedback from one hospital or one place. I think we've really got an enriched environment that's giving us a lot of helpful insight into how do they like the information on the screen, how do they like to code the interventions, which interventions need tweaking. We have a lot of people using it. Next slide, please. You know, we often talk about unintended consequences, and sometimes that has a negative connotation, but I think we actually had some positive unintended consequences. You know, we wanted to predict the risk of readmission, but as an added benefit, what we realized was the case managers and the nurses now had a better way to level the load of patient severity across the hospital. Our director of case management for any one of our areas could really take the 30,000-foot view, and maybe the staff used to say, oh, the people on 2B are sicker. It takes us longer. Well, now we know they are sicker. It does take longer. They're more complex. And we have ways that we can say, oh, on 4 Tower today, there's 18 very high-risk patients. Let's double up the case managers there and move them away from 3G. Now we have the tools in our hand that allow us to make those assignments, with a better scientific background. So now we're better able to manage workloads across the floors and the units. And if you're like we are, we're trying to document those interventions around transition of care. For some of you that impacts how you code and bill for those interactions. And now, because we've got the risk right there in our face, so we've got the risk, we know what quadrant the patient falls into, we know what interventions we've applied, we essentially have all the documentation that we would need to help explain why we chose a particular transition of care code for the patient. Next slide. So let's do a couple of quick slides on length of stay. We are now in the middle of building that model around length of stay. This was done at a request not only of our own institution, but from other hospitals and other systems that we were talking with. Having run a case management department myself in 2 previous hospital settings, I know how to use Milliman and Roberts. I know how to use the 3M tool. But the reality is those are static tools. And I can say, this is what those predict this particular patient will have. But let's say it's a 70-year-old with a hip fracture who is on Coumadin for AFib. We all know that patient's not going to have the same length of stay as what's in the book. Or perhaps a patient came in, on the first day, they were going to have some procedure done, everything looked routine, and on the third day they suffered aspiration pneumonia. We all know as soon as we hear that phrase, that patient's here for another 5 to 7 to 12 days longer. How can we get that risk model of length of stay to alter real time as the clinical picture changes? So, we have been working on this model now for several weeks, and just like our previous team, we wanted it to be multi-specialty, cross-discipline, and you'll see that we've included our hospitalists, our nurses, pharmacists, because when it comes to length of stay, there's a lot of internal operational variables that are impactful. It's not just the patient's clinical condition, it's also, do you have enough room in your stress, your cardiac stress unit to run enough patients through there in order to make it a safe disposition on this patient? Do you have enough time on the MRI scanner to add on this patient with a new onset stroke? All those things back up and obviously impact length of stay. Next slide, please. So we're going to show you some made-up screenshots. These say under construction, or please be patient with me, we're not finished yet. A made-up hospital, but you could see that if you are a case manager or a hospitalist, you might be looking at this made-up patient, Eric Hill. You'd see he's in for an MI. You know what CMS's average length of stay is. It's about 5.5 days. You'd know what your hospital's is, and you could see, Eric is right about what our hospital average is, but he's still here. If we don't do something different, he's going to be here perhaps another 5 days. Next slide, please. This screen shows us some of the typical information, again, that we might get from ADT data, but now we're able to include some notes. Who are the important experts or clinicians that are working with him? Who's that care team that is helping him through that process? And you see on the top right, that red bar that says risk of extended length of stay, very high. So something's gone on with him that's made him different than the typical person at this made-up hospital. Next slide, please. And then if you were taking that 30,000-foot view and you wanted to see all the patients in your particular wing, here's one that would show perhaps all the patients in a cardiac center. And you would say, Eric Hill, he was supposed to be there 7 days. That little bar on the right is moving from the blue space to the red space. It's giving me that quick visual of where that patient is. And as your eye scans down the page, you can see that the clinician or the case manager has ranked these patients based on length of stay, again, giving them a chance to alter their workflow. And then you also see, maybe Eric and Damon are the two I really need to focus on today because Michael and Matt seem to be, on schedule. But that's what we're aiming for, is a visual system, quick, easy to see. In fact, I should make a note about the colors of the extended length of stay. When we first put in the risk of readmission criteria, we used 4 color bands, and the staff on their own said, let's make magnets and let's make them line up with the colors on the Predixion screen. And so if I walked up today to any bed board and I saw a deep red bar magnet next to somebody's name, I'd know that that's somebody in a very high risk band for readmission. So there's lots of ways that you can visually give input and cues, and I think that's what all of us have wanted, because sometimes the most valuable information might be in the hands of the case manager, might be in the head of the hospitalist, but we couldn't get it where everyone could see it and work off of it. Next slide, please. So we should be finishing the length of stay module fairly soon. We're anxious to get that into production and next steps. And Nish, this is probably a good time for me to hand the microphone back to you.
Thanks, Jane. We really appreciate your time and sharing this information with everyone on the webinar. Just a couple of more pieces of information I'd like to share with the group, and then we're going to go into some questions and answer period. Here is an example of the different healthcare customers that are working with Predixion to bring predictive analytics to the point of care or to front lines where decisions are made. And then we'd like to also say to you that if you're interested in learning more about Predixion, we have a great opportunity for you coming up. We're co-hosting an executive roadshow series with Microsoft in the cities that you'll see in your screen. The Director of Case Management at Carolina's Healthcare System will be speaking live at these events. This will be an informative session on creating a data-driven culture in healthcare. You can register online using the link on the screen or going to the predictionsoftware.com website. I'll turn the floor over to Jennifer for any questions you may have. And again, we really appreciate you joining us today. Jennifer?
Thank you, Nish. Dr. Wright, excellent presentation. We're going to dive right into the questions. We've got a couple of good ones here. I'm going to go ahead and start with the dashboards that the case managers use. Are they embedded in another solution? The dashboards that the case managers or do they log into Predixion to access that information? Or do they log into Predixion to access that information?
This is Jean. Right now they log into Predixion and see that screen separately. But one of the advantages of this tool is it can be designed in a way that you could bring it into your EMR and see the score, and as equally important, see the variables that are driving that score. Or you could bring it into other CRM, ERM tools, case management tools. I think one of the things that we've heard from many of the case managers is, wow, on any given day we work with 4 screens that are open because of going from one application to another. So you can look at it individually, or it can be connected with some of your other tools.
Great, thank you. How often are the risk scores updated?
I think the risk scores are updated every hour. I mean, frankly, they could be updated every 15 minutes or every minute. I think as we build more and more of these models, we're going to realize some things need, a very quick turnaround, very quick change in clinical information that would drive something else. So when it comes to sending somebody home, we feel like whether it's every 15 minutes or every hour, that change is probably fast enough, and that change in the risk score and the interventions is probably fast enough. Later, as we look at things that have more of a real-time clinical impact, we may want to make that draw even faster. Nish, would you agree with that?
Yes, I would. I mean, the tool has the capability of being updating every minute. But I think that the way that it was designed to be deployed initially at Carolinas was to be accessed or updated on an hourly basis.
Okay, next question is, and this is very technical. I'm not sure that, Jean, you can answer this, but let's give it a shot. Question is, as a data scientist, I'm interested in the approaches used to recommend interventions. This looks like a rule-based classifier. Are there any deeper statistical processes at work here?
Well, I think your first guess was right. I'm not the right person to answer that. But if the writer or the person who raised that question will log that, let me get the right folks that are inside Predixion to give the best answer to that.
Great. We'll follow up with a response via email to that question. The next question here is, how can we better train our students to become healthcare data analysts?
Unmuted.
What kind of students were we talking about? Medical students? Are we talking about nursing students?
I'm not certain. It didn't specify.
All right. I know one of the things that came out of the ONC as part of the infusion of ARRA capital was new training around clinical informatics, and so many places in the country were able to access that money and expand training. I mean, it's a huge need literally across the country, having folks who have a strong clinical understanding but can also work with the information. We're in Charlotte. We're fortunate to have University of North Carolina Charlotte campus whose focus is on informatics in our backyard, and we still can't get enough groomed fast enough. I think that's one of the needs, and Nish may want to speak to this, is why Predixion saw a need for a predictive analytic tool that was, I think you used the word self-service, easier to use, not so scary for clinicians to work with. Nish?
Yeah, it's really a good point, Jean. And the key here is being able to expedite the process of getting that data into the hands of people who don't know or don't care what an algorithm is. And so that's, I think, as we talked about earlier in the presentation, it's really one of the things that makes Predixion unique in the industry is that we do have a very powerful enterprise platform that allows you to create, collaborate, build models, but also to be able to serve that up at the point of care so that you can make actionable insights on that data.
Great, thank you. The next question, and this may be a technical question, I'm not certain, but we'll give it a stat. For the ROC curve, which subset of patients was this analysis performed on? What were the sample sizes?
Oh, I can answer that one. That's a great question. In fact, we probably should have that built into this deck. 200,000 discharged. So we use the immediate past experience of our 7 hospitals in our metro area. We use every single discharge, and so that added up to 200,000 discharges. And I think that's one of the things that we realized was we needed a model that was built off of a large enough sample size so that it would really be meaningful, not only to us, but to others that would adopt it.
Okay, thank you. Next question. This is, hi, I was wondering if the COPD readmission rate has continued to decrease. Have the tools looked at other diagnoses? So that's a two-parter, Jean.
Right. Well, that particular work was grant-related and was just funded for 3 years, although we have taken our approach to COPD across the Carolina system. We don't yet have that data to see what COPD has done overall. And, for those of you who are listening that work on different readmission models, so many times the disease management approach is very specific, like the use of, home health or the use of parish nursing and a particular disease or particular area. And frankly, as difficult as I think that is to build, I actually think that's where people live life. It's got to be an intervention that really works in their environment. The reason a patient with sickle cell comes back to the hospital is usually a vaso-occlusive crisis and pain. The reason a COPD patient comes back is usually either an exacerbation, pneumonia, or anxiety. And the way you approach those two patients, really requires very different interventions. So, I'm deeply involved in our work here, and I really believe we have to have both and. We have to really be able to predict who's likely to be readmitted, and then we have to have a readmission prevention strategy that's around their disease and around their local resources.
Great, thank you. Next question. Do the case managers like this tool? And does it take them more time to do their job, or does it make it easier?
Nish, why don't you take this one first, because you're doing a lot of conversations with Jacqueline on this.
Yeah, you know, at the time that this was deployed, starting off with these first 7 hospitals, there was a lot of questions about, you know, will the case managers go through the additional screen that they use to serve up the number of patients, and then look at how they stratify those patients. And what's happened is that it's really changed the way their whole workflow. So when they come in for their shift in the morning or in the evening, they start off by pulling up the list of patients, and that list of patients will show, you know, which room all the patients are in, and it will show where they fit within the individual wristbands, very high, medium, or low, and they can immediately click on that and see which ones to go prioritize their workflow on. And so they approach their rounds now in a very different way, just as Jean was saying earlier in the presentation, by being able to prioritize their efforts, their time on those patients that are at very high or high risk, and then, you know, and sometimes perhaps not even work with the patients that are at low risk or medium risk. And in some cases, because the patients are being, the information about the patient is being entered into the tool at the time of admission, the first time that the case managers are even seeing this data is when they pull up that list of patients. So they're getting information about the patient even before they've had a chance to see them. And again, you know, the benefits of being able to prioritize their workflow around those that need it most has, I think, been very compelling.
Great, thank you. Okay, we have time for just one more question before we wrap things up. And this question is, what is the standard time taken for any of these installations?
Jean, if you'd like, I can take that.
That sounds great.
Okay, so, you know, it all depends. It all depends upon the data and the quality that the data is in, but it ranges from literally days to weeks, depending upon how much experience you have with the data and how the quality that the data is in is, again. So we can turn around an implementation within a few days to a week time, up to, say, 6 to 7 weeks, perhaps 8 weeks, depending upon the quality of that data.
Great, thank you. Well, I wanted to thank everybody for their time today, and as we wrap things up, I wanted to let you know that there will be a recording available of this session along with a PDF version of the slide deck that we'll be sending out to each of you. So be on the lookout for that, and feel free to share it with your colleagues. Again, thank you for your time, and we hope that you're able to join us at one of our upcoming breakfast sessions or a future webinar. Thank you so much.